All right. So we get to talk to you now about, maybe it's not a fun topic. Hopefully we'll have some fun today anyway. But I think a topic that's really important to discuss is when the interactions with our learners don't go quite as well. That maybe learners are exhibiting some behaviors that we might describe as difficult, where the teaching is not ideal. And how do you handle that? How do you deal with that in real time in the clinical environment while things are still going on? How do you kind of get things back on track? So we'll kind of go through some of these examples here. Hopefully this is what we'll cover today. Talk about some underlying factors that may lead to difficult learner behaviors, list some strategies that can be applied in the moment, and then how to apply some of those strategies. We get to do some more role playing here. I hope some of you have some experience being difficult. So here's some of the scenarios you might encounter in the moment. You've got a psychiatry rotator joining you from off service. You're halfway through shift. They've seen one patient. It was a patient with a psychiatric chief complaint. They were gone for over an hour. They had a really great time in there. They gave you the world's longest presentation about a psychiatric patient. Maybe the co-resident is getting a little antsy about that. Your resident from EM is like, I really wish they would chip in and help out a little more. But they came back and told the EM resident, well, what's the point? I'm here in EM, but I'm not an EM resident. I really just need to see psychiatric chief complaints. What do you do about that? Has any of you ever encountered anything like this? Is this real life at all? Yep, I see some nods. People have encountered this. This is not an entirely made up scenario. What do you do? How do you manage this in real time?
I try to frame things as like the purpose of their rotation is to gain some perspective on what other people are doing in medicine and how it contributes to your field.
Yes, absolutely. Absolutely. So bring it back to why are they there? And I think the takeaway for this one, when people have, maybe they just need some clear expectations. Hey, while you're here on the rotation, I'm going to expect you to see 3 patients from with a variety of different chief complaints. This is going to help you understand some of the medical complexity that you might encounter in your psychiatric patients. Maybe they've never been told this before. Maybe the other attendings that they've worked with have been like, it's totally fine. They can go off and see their psychiatry chief complaints and nobody cares. But if you want somebody to do something, let them know what it is you want them to do, because maybe they've just not been told. What about this one? They're kind of stuck in the mud. It's an early EM resident. They're also kind of slow. They're spending tons and tons of time with patients. Their differentials are kind of like, I don't know, like chest pain. I guess it could be a heart attack. They just order I put in some basic labs, and I guess we'll kind of see what comes back on them, and then we can kind of make some decisions from there. Has anybody encountered anything like this? Is this something that comes up from time to time? What do you do about this?
I never let them get away with this.
Yeah.
Does not exist in my mind.
How basic are we going to get? I've seen some people's version of basic labs be just a troponin, nothing else, no additional. Okay, well that's an approach. That's very basic. Yeah.
You have to frame their thinking that way.
Absolutely. I think that's awesome. I think a nice way to frame this that feels a little less threatening than, hey, I need you to do more, is thinking about things from the RHYME model perspective. So this is reporter, interpreter, manager, educator. And you can tell people, it's never going to be threatening if you tell them, hey, I feel like you're really giving me, you're more of a reporter right now. You're kind of telling me a little bit about this patient, but I'd really like you to move more towards an interpreter. I want you to synthesize some of this data and tell me what it means. So it's exactly what you're getting out of. Tell me what your differential is, and rank them for me. Tell me which is kind of more or less likely. So telling people sort of, hey, I need you to move to a different level on this model is sometimes a really nice way to say, hey, you need to get your act together and start doing your job here in the emergency department. This is a little friendlier way to get at that. Or maybe there's this case. This is the disappearing student. You've got a M4 who says that they really love EM. They want to go into the field, but they're gone. There's really cool cases coming in, and they're not there for any of them. They're maybe overly casual with the residents. They're watching videos on YouTube, pulling up Snapchat on their phone, and their differentials, they're really not that impressive a student. They're kind of giving you, right, oh, I guess it could be, ACS, it could be PE, but not really anything that's too thoughtful. What do you do about this person? Has anybody ever encountered this student? Yeah, unfortunately, this is real too. What do you do about this?
A lot of times we'll start with just a wellness check-in. Make
Yeah.
sure everything's okay first, that this is a behavior that's indicative of something else that needs to be addressed.
Absolutely. So really good thought here of like getting to the root causes of why. Maybe they were on the phone, on a phone call with their sick parent, and their mind is not in the game right now. What else? What other strategy might be effective for this kind of person?
Like the thought earlier about getting to the intent, like their intent is probably to be an amazing M4 student, right?
Yes.
So then maybe reorienting them to your expectations of what that looks like.
Absolutely. So exactly what you guys were getting at. So the advocacy inquiry of, hey, I'm really interested in understanding your perspective. What were you hoping to achieve with being gone or pulling up these videos on YouTube? Maybe they were trying to prep for a procedure and were trying to do some of that just-in-time teaching for themselves. You thought that they were slacking off, but actually they were really trying to be impressive and engaged so that they could really knock that procedure out of the park. So trying to understand their mindset, their mind frame is super important here. These are some of the nice advocacy inquiry prompts that you can use. Hey, I noticed this. Again, talking about what you saw, keeping it very objective, and then trying to get to some of the roots of some of that.
All right. So then there are some of those conversations that are going to take a bit longer, right? Maybe you don't have time at the moment to delve into kind of your wellness check with that person, or it seems like it's a more complex issue, and so you're like, okay, after this shift, I'm gonna sit down with this person and chat about this thing. And so some of these are similar to some of the things you've heard about with the R2C2 model, right? The building the relationship, and we're calling it the educational alliance. Whatever you want to call it, right? You're going to tell that person and have them understand that you're on their team, right? You want to help them get to that next level, to minimize some of that defensiveness, right? You want to get out of that, like, you're telling them they did something wrong and they're trying to defend it, right? You're trying to team with them. You're trying to partner with them to figure out what those next steps are going to be. And then in a lot of these situations that seem like they're more complicated, guided metacognition works pretty well. And so metacognition is just thinking about your thinking, right? And you're helping them do that. And so you're going to help them kind of walk through what happened, why it happened, what their thought process was that got them to that action or that inaction or that behavior that was generally probably negatively interpreted by somebody, right? You want to explore what led to that behavior or that action. And so this often takes a lot of questioning, right? And you guys started learning this in your R2C2 practice, right? Some of you were doing kind of multiple layers of questioning to get to that underlying etiology that caused them to do something or behave in a way that somebody didn't like. And then, same as R2C2, then you're going to come up with a plan for the future, right? You're going to brainstorm, okay, well, what can we do differently next time? On your next shift, what do you want to do differently to have your actions interpreted differently or have, your intentions interpreted differently on future shifts? And then come up, same thing with a goal for the next shift that they're going to work on. Sometimes your next steps, depending on what it is going to be that you have to escalate this issue, right? If there's gross unprofessionalism, right, something that is totally inappropriate, their program director may need to know about that. If this is an issue that's been going on, you've worked a number of shifts with them, you've given them feedback, nothing's improving, you're really worried about their performance, their program director may need to know about that. So some of that at the end may be, okay, hey, let's chat with the PD and see if they have any insights or other ideas on how to help you kind of move through this.
Because even if you think it's a one-off, it's probably not a one-off.
Yeah. So thinking about how you're going to have this conversation, these more difficult conversations take preparation. And so first you're going to synthesize your information. The SOAP mnemonic is one that, like we all know, right? Same as SOAP notes, subjective, objective, assessment, and plan. You're going to think through this ahead of time. And so here's an example, right? This is just a more simple example, but this, end of year G1 did this terrible HPI on a chest pain patient. You're like, you're gonna be a G2 soon. Like, really? You can't ask, the important questions? And so you're disappointed or annoyed, right? You're like super annoyed, like, what's going on here? I've been teaching you all year and nothing is sticking. So acknowledge your feelings and then let them go, right? This I'm annoyed with you doesn't need to come into your conversation, right? You want to focus on the objective things. What was it that annoyed you about the HPI? Oh, it's that they didn't have the timing of the chest pain. Was it intermittent or constant? What time did it start? They didn't ask whether it was pleuritic, if they had PE risk factors, etc. These are the things that go into your conversation because like we talked about earlier, you want those objective pieces of data that you guys can talk about that they're going to work on in the future. And then your assessment and your plan. Your assessment, just like your patients, you can't come up with a treatment plan until you know the diagnosis, right? You have a differential in your head of all the reasons they may have done this terrible HPI, but you're not going to know which one it is until you do this guided metacognition with them and kind of figure out what their thought process was and how they got to where they got to. And so, that assessment phase can go anywhere. They might even come up with things you didn't think about. And so some of this is going to be on the fly in your conversation with them. And then you're going to use some of this advocacy inquiry. So, I noticed in this patient, we didn't have some of the information that might help us come up with a good workup plan, right? Not you didn't get the information, but we didn't have this information. I'm curious as to how you determine what questions you ask every chest pain patient. And using this in the multiple layers, I think, in that way will help you get to the information you need to get to. So what we're going to do now is we are going to give you guys practice time. So on your tables, I want you guys to get in groups of 2 again. So on your tables, you've got case A and B. So maybe, Danielle, if you want to come up here, you guys are case A and B, and then you guys have a case B and C. Divide them however you want. When you open the envelope, there's a bunch of normal size paper. So the 2 of you in the group can both read what the attending noticed. Then one of you is going to be the learner. The learner instructions are in a little triangle. So the only person that gets to read what's in the little triangle is the person that is the learner. And then you're going to do your mock conversation, and we'll come around, we'll split up just like we did before and kind of be the observers to your conversations and see if we have other feedback.
One person learner, one person faculty, and then as soon as you have read your